Hey everybody, Dr. Tom Moorcroft back here with you for this episode of the Healing from Lyme Disease Summit. And today I have the great honor and privilege to be chatting with my great friend and our co-host, Dr. Darin Engels, for this interview. So Darrin, welcome.
Hey, it's always glad to hang out with you, Tom.
Darrin, it's always tons of fun for me to sit down and have these conversations, and really be able to share your expertise with other people. As a lot of people know, like one of the things that like is important to me is marrying sort of like, the best of all the things that we have out there, and especially being true to science where we have science to guide us. When we don't have that science, that's kind of where and even the implementation of the science is so much where the art of medicine comes from. But one of the things that I've always appreciated, whether it's through your Lyme Solution book or just our conversations that we've had privately or a lot of the public work we've done together, it always is that balance of the science to me, which gives hope. And then how do we apply that science to the person in front of us? So I'm always really happy to have the ability, the opportunity to have a conversation where we can dispel some myths, maybe lay down some good street knowledge and help people. So I think we're going to be talking about. Anytime we talk about chronic infections, Lyme disease, we end up talking about immunity and autoimmunity. And, one of the things I don't know if people know about you, you're a microbiologist as well as a naturopathic physician. So you are uniquely qualified to talk on this topic. But so what are some of the important things that we, just sort of maybe the top down approach, what are some of the important things that we need to start considering when we think about Lyme, other tick-borne infections, and this bigger topic of immunity, autoimmunity?
That's a great question. I think one of the biggest hangups that people get when they get exposed to Lyme and really any other tick-borne illness is this idea that the infection is responsible for the totality of everything they experience. And you and I know that that's not really the case in most cases. It's a combination of what that infection does. We know that Lyme and Bartonella and really any number of these other infections can be catalysts for autoimmunity. And of
Mm-hmm.
course, people with chronic infection, they've usually got a litany of other things like mold illness and other environmental toxicities and yeast overgrowth and heavy metal poisoning, and it kind of goes on
The
and
whole
on.
nine.
So, we're always, looking at the whole of the person. So we're not just hyper focusing on the tick-borne illness, but looking at all these other factors. And this autoimmune piece, I think this is, if we want to say there was any advantage of the pandemic, I think the one thing it really highlighted, though, that we saw so many parallels to COVID and Lyme, right? In terms of you've got this agent that's difficult to test. We don't really know what the test results mean. We're still treating people clinically, and then we get these people with long haul syndrome. I think everyone in the Lyme world, kind of said long haul. Welcome to our world. We've been dealing with this for decades. And one of the things that we know from the research is that Lyme and these infectious agents, again, are catalysts for autoimmunity. And what's confusing is if you go to the rheumatologist and you get standard blood work done, more often than not, your blood work looks pretty normal. You run a CRP, which is an inflammatory marker. You might do rheumatoid factor or an ANA. And I find a lot of Lyme patients have this very low titer ANA, but it's not enough that really qualifies for having an autoimmune disease. But we know that the kind of antibodies that are being produced are not the kind of antibodies that we're testing for. So if you go to Quest or LabCorp and your doctor orders a battery of blood work, again, most of it's going to come back looking pretty normal. But if you start looking at where these organisms target, well, we know it targets the gray matter. I mean, Lyme in particular, Borrelia, the gray matter of your brain, the white matter of your brain. Oh, well, what's that going to mean? Could be migraines, could be headaches, could be brain fog, could be sleep disturbances, could be mood changes. We think about all these neuropsychiatric symptoms associated with Lyme, and they've got this idea that Borrelia is this organism that digs a hole in your brain. It doesn't do that. Yes, we have found Borrelia in and around the brain, but it's not like a gopher that's tunneling a hole and it's eating your brain apart. That's not really how it works. But it can become an immune trigger that cross reacts with your brain. We know what can happen with your peripheral nerves. What's that going to translate to? Well, that's neuropathy. That's numbness and tingling and these weird, creepy, crawly sensations. And people who feel like they got a second-degree sunburn all the time, that can be an autoimmune reaction to your nerves. We know it can be an autoimmune reaction to your joints. Well, you get chronic joint pain. Is it an infection in the joint? I mean, come on, how many times have you had patients that go get their joints tapped? They don't find any evidence of infection. Typically when there's infection, you'll see blood, you'll see white blood cells, you'll see other
Mhm.
changes in the fluid. And we don't typically see that with Lyme arthritis. So, we get into this fine line of, well, how much of it's the infection and how much of it's the autoimmune reaction to the infection? And maybe to compound this a little bit more, not to confuse everybody, but this is a common scenario. You go to the doctor and they say, okay, we need to run a Lyme test. We're going to do all these other blood tests because I don't really know what's wrong with you. So we're just going to order the kitchen sink. And then they start ordering all these other viral titers. Well, maybe you've got Epstein-Barr or parvovirus or whatever else. And you get this lab report back that's usually like 20 pages. And you start seeing all these hits. You got IgG to herpes 6, you got IgG to Epstein-Barr, you got IgG to all this stuff. And you look at it, and if you didn't know better, you go, wow, man, my body is just getting riddled with all these infectious agents. And take a deep breath. The good news is that's not really what's happening, at least in most cases. And, we see so many people that say they have reactivation of Epstein-Barr, and that can happen. But more often not, what we see is that we'll see high IgG titers to Epstein-Barr and not necessarily IgM, which is the antibody that we associate more with acute infection or at least active infection. And sometimes that comes up, but more often not, that doesn't. But when you start to see all these high IgG titers, there's a concept in immunology called polyclonal activation. And polyclonal activation is essentially your immune system kind of freaking out, saying, hey, something's going wrong here. I'm not sure what it is, but I need to, amp up my defenses because something's trying to invade me. Something's trying to attack me. So we'll see that there's kind of this broad stroke up leveling of your immune system. And therefore, when you were doing antibody testing, that's part of your immune system, you start seeing, high levels of all these different things. So, when it comes back on your blood work, the good news is you don't have to panic or freak out about it. In many ways, you can say this is almost maybe a good thing that your immune system is responding. It is maybe not responding in the way that we want it to, but it is showing that there's some activity to it. I would worry more about someone who has like no immune response or has a very poor immune response. But this polyclonal activation really gets overlooked in medicine, and people tend to misread it. Even a lot of our colleagues, that they then start you down this treatment path of wanting to get you on antivirals and kill all these other things that may not necessarily be causing a problem for you. So I know you and I, we try to be very thoughtful and selective about what we're giving our patients, because it's easy again to throw the kitchen sink at people, which it's expensive. It can be hard on the liver and hard on your other parts of your body. They have to process all this stuff. So we want to be mindful about whatever recommendations we're giving you. There's a purpose, there's an endpoint, there's something we can measure for that. But I just wanted to mention it because, again, it's such a common thing I see in my own practice. And I just want people to realize that, it's very easy to get bamboozled in this world. Much like, again, if you do a Lyme test, your Lyme test comes back negative. Does it mean you don't have Lyme disease? No. It just means that for that particular test kit, it didn't show up. And I guess I should qualify this again. I was a microbiologist before I was a doctor. I used to do Lyme testing for a living. And if you think about the standard Lyme testing, this is how crazy it is. So, when we would run a new test in the lab, you would always have to go through and do some sort of study to compare it with a previous test, another test kit. You need some measurement of a gold standard to know that your test kit is accurate and the results you're getting are reliable. So tests are measured by their sensitivity and specificity. So the sensitivity is, if you have the disease, what's the likelihood you're going to pick it up? And the specificity is it specific to the disease that you're looking for? And generally speaking, you want both to be at least 95% or higher, or at least somewhere in that range. Well, if you look at the research on the Lyme screen, so if you think you have Lyme disease, you go to your primary care doctor, the first thing they're going to order is a Lyme screen, which is an IgG and IgM antibody test. And we know from the research that the sensitivity of that test is somewhere between 43 and 46% sensitive. literally misses more than half of the people that have Lyme disease. That, by all standards, is a terrible test, a terrible test. And, you know, myself, I mean, I had classic Lyme disease. I got bit living in Connecticut. I lived 30 minutes from Lyme, Connecticut, and I had all the classic symptoms. I had the headache, the bullseye rash, 105 fever, neuropathy, you name it, I had it. And when I went into the lab and did my Lyme screen, the test came back negative, completely negative. And then I did
And
the
you had a
Lyme
rash.
Western blot, and I had the rash. And I
Wow.
waited like, 2-3 weeks afterwards. It wasn't like I did it right away and I might have missed the window. I'm like, no, I knew enough to give my immune system a chance to respond. And the screen was completely negative, but I did the Western blot, which is a more specific test of IgG and IgM antibodies to Lyme, and it lit up like a Christmas tree. And this was through Quest, which I would say is not the greatest test kit anyway, but even then it came up. So, we've we've got these issues around how the immune system responds to Lyme. And this is why, testing can be a bit problematic, because if you don't make a robust immune response, your test is going to look negative. We know there's a threshold that every test kit has because it compares you to a control. If you don't meet that threshold, they call it negative. And the threshold that's set is generally pretty high. The idea is that if you have Lyme, you make a lot of antibody. And in concept, that sounds great, but in reality, that's not always true. And one of the labs I work with, MDL, they've changed their test kit, but when I started doing it with them, they would actually send me a copy of the patient strip and the control with the percentages, and it would come back at 59%. I'm like, well, that's a function of how much water you had to drink that day. So that's the difference between you do or do not have Lyme disease. That makes zero sense. So, depending on how far you get away from your exposure, we know that immunity naturally wanes with time. So if your exposure, like most of our patients, happened months or even years ago,
Right.
the likelihood of picking it up on a Lyme test goes way, way down. And of course, if you're on any medication under chronic stress, there's a gazillion things that can suppress your immune system and therefore alter that antibody response. That's why, again, at the end of the day, Lyme disease is a clinical diagnosis. If you go to the CDC's website today, it says it's based on signs and symptoms, and particularly if you live in an area for endemic for ticks. So I just wanted to throw that in, and we're talking about immunity, that this is very relevant to testing. And I know so many of you tuned in have been gaslit by your doctor. You've been completely dismissed because you didn't have a Quest or LabCorp CDC positive Lyme test. Or even worse, you live in a place where they said Lyme doesn't exist. I mean, I live in Southern California now. I lived in Connecticut for 20 years. I've had doctors tell patients there's no Lyme in California, despite the CDC saying California is the 5th fastest growing state for Lyme in the country. I even had one doctor tell a patient there's no deer in California. I'm like, dude, you need to get out of your house more, because there are deer all over the place. You'll see deer crossing signs. You'll see deer everywhere. And deer aren't even the biggest vector anymore, by the way. But this is sort of the medical system that we're working against, and just trying to get an accurate diagnosis.
It's really interesting, man, because there's so much misunderstanding, and I think it's really important to kind of talk about that sensitivity and the specificity. So a couple questions like about sort of the viral titers and stuff. So if one of the things I see, and I've always sort of wondered about, is you'll see people who will have like all their viral titers are like through the ceiling, like, and picture perfect. They meet like kind of like that polyclonal activation. But then I go and I do a Lyme test and I got like an indeterminate 23 and nothing else.
Yeah.
So, and I'm sure that this is a question that a lot of people have. But from that microbiology and as well as your clinical experience, like what does that actually mean?
So think about this. You've got really two parts of your immune system, if you want to think of it this way. It's maybe more, I'm trying to take something that's horribly complex, but to simplify it, when you make antibodies, your immune system is designed to create sort of two types of antibodies. It creates antibodies that are non-specific, that just says, I don't know what you are, but you don't belong. You're not part of me. I don't know who you are. And so whether it's a virus, a bacteria, a fungus, a parasite, you get those antibodies. And then you get other antibodies, which are, oh, I see your Epstein-Barr, you don't belong. And so my antibody is very specific to you. So in polyclonal activation, you can get activation of a non-specific antibody, but even within that antibody type, it may target different antigens differently. And particularly with herpes viruses, because they're in the same class. So Epstein-Barr, CMV, herpes simplex 1, simplex 2, herpes, human herpes 6, varicella zoster, chickenpox, all of these are herpes viruses. So that's often why we see herpes viruses will have these sky high titers, and it doesn't mean you have all these viruses, but because there's so much cross reactivity of that antibody amongst that family, that's often why we see it. Because I'll see this where, we'll get a lot of herpes viruses where the titers are high, but not necessarily parvovirus or a virus that might be of a different camp. But I think that's why sometimes we see these really high viral titers and not necessarily a high Lyme titer. It's just even those non-specific antibodies aren't necessarily specific for that antigen that we're looking for.
Nice. That is like literally the best description I've ever heard of that. And it is definitely totally accurate and super simplified in a way that I think is just great, Darren. I love it because, it's complicated. We talk about all these different pieces. And one of the challenges that I run into, and it sounds like you do as well, and I know so many of our other colleagues do, is it's so hard to say to a patient, hey, I've gone to school for like 27 years in a row to become a doctor. And so it's going to be a little hard to maybe for me to explain to you why like 7 different herpes viruses reacting, is not directly related to your Lyme test. And you don't have all these things. So I think that's just kudos, man, like well handled.
Well, you and I talked about this in my interview with you, so folks want to go back and watch that. But I want to bring it up again because, again, this is an important point. When people, as they identify with their illness, got to be very cautious about. I mean, I know it makes both of us a little crazy when patients walk in and go, "My Epstein-Barr is terrible today. My Bartonella is terrible today," and as a practitioner, that doesn't help you in the best way because we want to know about what symptoms you're experiencing. And again, it's very easy to chalk up something to being a viral illness or being Bartonella, but in reality, it may or may not be the thing that you think it is. And that's an important distinction because it's hard for us to gauge, how best to treat you. I mean, I can do a lot more when I know your neuropathy is worse, when you're having more foot pain, when you're having more migraines versus my Bartonella is acting up today. So it's helpful as someone dealing with a tick-borne illness, keep good track of your symptoms. That's going to give your practitioner the best way to guide you on, whether you need to change your treatment protocol. But be careful about using this kind of language just because I find more often than not, it's not the case. Often we'll do tests. I mean, I've had patients tell me they're absolutely convinced they have Babesia because they've got air hunger. And we've done a gazillion tests for Babesia and nothing comes up. And by the way, Babesia, because it's a blood parasite, is not difficult to diagnose. You can actually put it under a microscope and you will see them inside your red blood cells because that's where they live. So if you've done several tests and you can't find it, that probably doesn't explain your problem. But we talk so much about mindset, and I see so much of this like in training in the brain that you convince yourself that certain symptoms are related to this one specific thing. And the downside to that is that sometimes cut you and maybe your practitioner off of exploring other possibilities. If you've got it in your head that it's absolutely Babesia and you need to give me Babesia treatment, and if you don't give me Mepron and azithromycin, I'm going to go to the doctor down the street who will.
Oh, and artesunate and tafenoquine and blah, blah, blah.
And that doesn't serve your higher purpose because, you've got to give your practitioner an opportunity to make their own assessment, examine you again as a whole, but again, understanding how your symptoms change. Because again, we don't have a biomarker out there that tells us how you're doing. And I've argued with other doctors, if anyone out there can give me a good rational explanation of any one biomarker out there that we can measure on a blood test, imaging study, again, for someone who worked in a lab for years before being a doctor, I don't know of any biomarker that we can apply to everyone. CD57 is not helpful ever. And nobody I know with Lyme, they said, well, my CD57 is low. I'm like, what was it before you had Lyme? I don't know. Nobody ever measured it. I'm like, so is your CD57 low because you have Lyme, or do you have Lyme because you had a low CD57? Who knows? So again, in absence of a good biomarker, at least to date, we rely on how your symptoms change again to give us guidance on whether our treatment's doing what we want it to do, whether we need to change protocols, or do we need to start investigating other possibilities. I mean, you and I have both been through this. I mean, now hundreds, thousands of times with patients where they do 3, 4, 5, 6 different Lyme treatment protocols and they feel no better. At what point do you draw a line in the sand and go, maybe this really isn't Lyme?
Mhm.
Maybe there is something else that we're overlooking. And again, mold illness and Lyme, there's a lot of clinical overlap. There can be other factors, toxicity of different types. So again, I never want to hang my hat that everything you experience is just Lyme or tick-borne illness, but be clear with your practitioners. And again, if you've got brain fog, write it down. I know it's hard to remember when you go to your visits, and sometimes it's months apart and you can't really remember. So keep good notes, keep a little log, pull out your phone, just keep little notes on
Send
how
us
you're
a
feeling.
portal message, like an email, just,
Yeah,
hey, so
we're
you don't
all,
even have to remember.
we're in a technological age where it's really easy to track this and communicate with your practitioner, but that helps us tremendously. And again, being able to give you the best advice based on our experience and what you're feeling to know whether we need to change treatments.
Darren, I think it's so important what you're pointing out, in that, like, I have a patient that I've recently been talking to who had an atypical presentation of C. difficile, right? So what we found, though, was they didn't have C. difficile colitis diarrhea, but so Quest won't even do their test. We do testing through another company. We find it, and they're symptomatic with GI symptoms, but then so someone treated them, and because they're getting antibiotics during this whole period of time before they saw me, so they basically got 3 different episodes where they had C. diff. And I've been working with them with an herbal protocol. Everything's been good. They added in an extra herb, like on the side. Turns out it's very active in the gut. All of a sudden, other C. diff symptoms come back. And and I was just like, okay, so I know I wrote down what your C. diff symptoms were last time, but what symptoms are you experiencing now? And they're like, my C. diff symptoms. I'm like, no, actually, rewind and answer the question. And I mean this lovingly, because my point is, they told me the story of what their C. diff symptoms were, exactly like what they had experienced in the past. We decided to do a C. difficile treatment because they had responded to it in the past and they were suffering. I said, I will prescribe this medication to help with this, but our deal is 4 weeks after you finish it, assuming that we however long we have to treat it for, but it should only be like a 10-day course, that you're doing a stool test so I can find out why you're getting back. And again, we can argue stool tests all day long, and I chose to do a different one than they previously did. But
Yeah.
my point being is, going back to what I said, like you brought up when we were chatting and when you were interviewing me, is like, I don't care what's wrong with you. I don't care about the label. I just need to know what it is. And if you're getting symptoms that you're calling C. diff symptoms, and someone's able to isolate an overgrowth of C. diff without colitis, I want to know why, because you're suffering from it and I want to help you get better. And I remember, and you reminded me of a patient I saw from Florida. I had seen family members from the Northwest, mid-Atlantic, or wherever that is, up above me near Chicago. I don't even know where that is. But the point was, they had referred some folks from Florida. I saw mom and the kiddo, and they had Lyme disease. They had really classic symptoms, labs lined up, response to treatment lined up. So then, this lady's husband was like having brain fog, joint pain, and fatigue all of a sudden. And he hadn't left Florida in a while. And so he goes to his doctor, and I'm assuming I know how the conversation went, which was, my wife said I had Lyme, so I need you to test me for Lyme. And the guy's like, there's no Lyme in Florida. They did an ELISA and kicked him out. This guy came to my office from up in Connecticut from Florida, had a thyroid stimulating hormone, a TSH of 97.
Oh, that's a little off.
So he was severely hypothyroid.
Yeah.
And it just so happens that Lyme disease is not treated with thyroid, but brain fog, fatigue, and joint pain can also come from low thyroid. Getting the right test, he didn't have Lyme. There are actually people who don't have it, to your previous point.
Yeah, well, again, I think this is a common scenario, particularly within family members, that if one family member has Lyme, other family members start to experience symptoms. Particularly, I see this a lot with moms and their kids. They're so afraid that they, had congenital Lyme and they pass it on to their children. And again, in my experience, it's actually been a very rare circumstance I've seen of congenital Lyme. But if you live in the same area, it's possible that a child could develop it just because it's out there in the world. So it's tricky to navigate, but I just want to encourage everyone who's listening again to be just thoughtful about keeping track of your symptoms. Again, it's going to help you and your provider give you the best path to treatment, because again, we sometimes get so caught up in the lingo that or the label, that we're not really addressing how these things are changing. And again, because that's our best way of managing your care, we rely on what you tell us on how things are changing. I think one of the hardest things that we both experience, particularly if it's been a long time between visits, and you're like, well, what's changed? And they kind of go, I don't know, or everything's the same. And if you're starting from here, here, and you get to here, but you want to be here, it's very easy to minimize that difference between here to here, that little bit of improvement. And as we start going through and like, well, do you still have headaches? Oh, well, they're not as frequent and they're less intense. Okay, so the headaches are actually better. Do you still have insomnia? Well, no, actually, I've been sleeping a little better. Okay, so your initial knee-jerk reaction is I'm no better. And we come to find out as we dig a little deeper that you're not 100% better. And of course, that's our goal. But when we see those little things changing, for some people, Lyme treatment's like watching freaking grass grow. It's painfully slow. But that slow, steady progress, I mean, as slow as grass grows, it does grow, it does change, it does move in the right direction. So I'm always very hesitant about changing people's protocol when I see improvement, because I don't know about you, but I've had the experience where the progress is slow, people get impatient, and nope, we need to change protocols. And against my better judgment, we change it, and then we lose all the gains. We get more die off. Something bad happens, and I keep thinking in my head, I'm like, why did we do that? Why did we change? And I know why we did it, because you wanted a faster improvement. I felt bad that you weren't improving fast enough and compromised. So, I mean, I've been doing this long enough now, I don't really do that anymore, but this happens a lot. So, there's a process in which your body heals. Again, it's built into your DNA to heal. We just need to get things out of the way to allow that process to happen. And everyone heals in a different path. I mean, I had literally, in the thousands and thousands of patients I've treated in 24 years of doing this, I've had literally one patient, one, who came in with very severe neurological Lyme symptoms. And in my mind, I'm thinking, man, she's in for a long road. I mean, she had bad neuropathy, bad joint pain, migraine headaches, terrible brain fog. I mean, all of it. And she comes back a month later. I changed her diet. I put her on Chinese herbs, and literally every single symptom went away, 100% gone, not an inkling. And I monitored her for many years after the fact, never came back. So, we get those cases that people can respond very rapidly. I would say that's definitely the exception more than the rule. But just understand that your body has a wisdom. There is a process. Our job as your practitioner is to make sure that we're keeping you on that right path. But be aware that if you start taking matters into your own hands too often without talking to your doctor, more often than not, that ends up making a mess. And I just had this conversation with a relatively new patient I saw who's got PANS, probably has Lyme disease, and the parents want 3 or 4 different doctors all involved in the case. And I'm like, well, that's great, except you're going to get very different opinions. We all philosophically on different pages of the best way we think to approach it. And again, as parents for kids with Lyme, it's really confusing. And as you as the patient, it gets to be very confusing. So I think at the end of the day, you need a captain of your ship. You need someone who's really minding the store and can give you that guidance. And you got to trust the person you're working with. If you don't have the faith and the trust in that person, please find someone you do. Because honestly, I can promise you, if you don't trust the person you're working with, You're always going to be second guessing what they're recommending. You're going to go on the internet. You're going to read something that contradicts what that person told you. And again, it just creates more anxiety, more fear, more hesitation. And then it just leads to paralysis. And then you end up doing nothing. So it's in your better interest to, again, find someone that you feel jives with your philosophy on health and healing, hears you, understands you, is willing to work with you. I mean, again, we might be the captain of your ship, but it's still your ship. And, at the end of the day, you make the decision that you think's in the better interest of your body, your health. We're here to give you our best advice based on our experience. But, you've got to have somebody who really is minding the store for you and can give you that good advice.
Yeah, I got nothing to add. No, I mean, it's so well said. This is like, if you want to know, it was funny. Like, I was watching a YouTube video the other day by a reptile breeder, and like all these people are talking about, they make these videos of what they don't like about reptile breeders. And he's like, this is what you want to do if you want to piss off your breeder. And I think one of the things that I see in my practice is exactly what you said. It's so frustrating to dedicate your life to helping people with this, to teach them before and they come in and when they are first coming in what your philosophy is, so that they can know they resonate with you, and then to have them just looking and looking, and I think for a different answer. And it's not like you can't have different people on your team, and it's not like you can't have a consultant. But one of the things that's so important of what a consultant means is they're supposed to consult and give an opinion, and the captain of the ship, the primary provider, is supposed to be the final filter. And one of the reasons, Darren, I think that what you said is so important is, yes, all the patients are captains of their own ship. Ultimately, it's their life, their health, their insurance, their everything. They have to make the final decision. But one of the, and I am, as you know, from watching the summit and all my interviews, and when Darren and I talked and he interviewed me, I'm so into you taking back control over your own health. But the part that we have to talk about, I think, is your doctor, your provider, whoever you choose to work with, generally speaking, will have a more objective view of what's going on in your life than you will. And this is a part where it's hard to be, why they tell doctors not to treat their own family. Tomorrow, my daughter has an appointment with a pediatrician. Both my wife and I are board certified family practitioners, and I serve as pediatricians for many people. I don't need another pediatrician, but what I do need is a pediatrician who's not me, so that I can take the time to be a parent. So as a patient who's a consumer of all this amazing information, as you're talking, Darren, I was just thinking, like, the summit, you will hear differing and diverging potential possibilities. And this goes back to kind of like when I talked with Paul Anderson, and great interview, we were talking about the difference between a protocol and a plan. And Darren and I and everybody that we've brought onto the summit have many different protocols, many different possibilities that we would like to put into a plan, which is, we sit down, we talk to you, we get your subject, all of, your story, the changes that have happened in between appointment, we get all the relevant lab data, and then we make a decision on what next step to take. And when we do that, the way we decide what the next step in the plan is to see how your body responds. So all this, like, comparing yourself to everybody else, stop it. Literally go on YouTube, look up Bob Newhart and stop it. Watch that video and stop comparing yourself to other people. It is the number one way to fail at life and fail at healing. So Darren, I just wanted to piggyback on what you said. So key. One of the things
I was just a quick add, wherever you are today, whatever you've done, as far as you've gotten, that's the result of what you've done. And if there's still room for healing and improvement, I mean, there are literally many ways that you can approach that. So again, I think it's that mindfulness of, having that understanding about whether you're on the right track, and, be clear about that. On the back end of that, I just want to add that if you've been on a particular plan for a certain period of time and there's been no improvement, I mean, in anything, you also need to have that conversation with your practitioner about, okay, maybe now it's time that we need a different plan because this isn't working. I also get frustrated where I see people who've been on the same plan for 6 months, 12 months, and there's been zero improvement in any of their symptoms. I'm thinking, what are you waiting for to see the needle move it? I mean, that's been well enough time that if that was the right approach, you should see something change. So there's that balance between be patient enough to see some improvement, but don't wait so long. So for me, just to put it out there, 2 months is my benchmark. Whatever plan I start with people, I give it 2 months. If we don't see really anything move at all in 2 months, then we'll change plans completely. If we see some improvement on some things and maybe on others, then maybe it just needs a little bit of a tweak. We just make an adjustment. But again, this is where you got to have that conversation. Make sure you have your follow-up appointments and whatever that time frame is so that you're in contact and you're not letting it slip through the cracks.
Yeah, and one of the things that's interesting too is you mentioned die off, and it was funny. Like, I was looking for a crack, and I have a particular patient now, floridly positive Lyme, Bartonella, Babesia, like literally like easy peasy, like the easiest diagnosis ever made. Do all the treatment, nothing happens. It's probably like we've tried different things over 4 to 6 months. And somewhere in that mix, I go, well, with your history, you probably have mold exposure. So we have mold exposure in there. And oh, that's what's blocking the Lyme, the Bart. So then we start working on it, Darren, and like nothing changes. So then I'm like, well, there's a problem there. And they're like, well, I have this reactivated Epstein-Barr pattern. And I'm like, well, based on what you were just talking about, probably not, but nothing had changed. And I was like, let's give it a shot. Let's work on that. Herbs didn't do anything. Medicine didn't do anything. And I'm finally like, dude, we got to relook at some of this. So we're missing something. And when I first met him, his testosterone was like this. But after we kind of tried to treat all these, it was really low. So then I get him on testosterone. He feels horrible. And I call all these like male hormone optimization people I know, because I thought I knew the answer, but they were all like, they should just feel better. And the only thing that any of us could come up with was that now this person's system had the strength to actually go after what it needed to go after. Right. So a lot of times when people are telling us something's acting up, like we've been killing this horse, unfortunately, like beating it over and over. But it's like, we need to know your symptoms so that we can figure it out, because low testosterone, low thyroid, and Lyme all look pretty similar too. So my question kind of comes back to this, though, is because this person essentially looked like they were having severe die-off when I started to optimize their testosterone. But it seems to me, Darren, that like so many of our patients are saying that any negative experience they have is a herx or a die-off. What are you seeing? Like, how do you define die-off? Maybe touch on Herxheimer so that people understand what this, but what is going on in the immune system that is this? And is everything that's kind of negative or a die-off a bad thing?
Yeah, that's a great question. I mean, this is
I pulled it out of my rear end just now, so.
Well, no, I mean, this is a thing I see a lot in my practice where I think people aren't fully understanding what a true Herxheimer reaction is. So, I mean, immunologically, it's kind of a combination of the organism literally dying off. I mean, if inside the organism, if the balloon pops, it releases all its inner constituents, which can, provoke the immune system, and it's the immune reaction to the organism itself. We know that Lyme is an incredibly slow growing organism, and the best time to kill a bug is, at least the bacteria, is when it's in a replication phase. So that's often why people like every 2-3 weeks might have a worsening of symptoms. That may just correlate with the replication cycle of the organism. So the die-off reaction itself, again, is kind of this combination of the balloon popping with the immune activation against it. A true die-off, though, tends to be more of like flu-like symptoms. It can be fatigue and headache and just kind of that blah, yucky feeling. Sometimes it's just an exacerbation of their current symptoms. However, a true die-off reaction should be transient. It can be anywhere from a few days up to maybe a week and a half, probably no more than 2 weeks, because again, if it's correlating with the life cycle of an organism, at some point that life cycle is going to change. It doesn't go on and on and on. And I've seen people that tell me they've been herxing for 3 months. I'm like, no, dude, that's not a herx reaction. That's you having a problem with something that you're taking. That's you having some other adverse reaction to whether it's the antibiotic, the herb, another supplement you're taking, but there's something in your program that your body's not agreeing with. So if it really is a true die-off, again, that should be relatively transient. If you've been herxing for more than 2 weeks, probably the likelihood of it being a herx reaction is pretty low, and you're probably having some sort of adverse event from something that you're taking in your regimen.
Hallelujah, preacher. Like seriously, like I'm happy we're able to dispel some of these myths. And to be clear, Darren, I don't hear you saying something's not happening. What you're just saying is the label of what's happening is incorrect, which then delays us in figuring out what's really wrong. Again, going back to tell us what's happening, not the label that you put on it. Because yeah.
Well, I think so many people with Lyme at some point, and I see this often for a lot of people after they had Lyme, before they had Lyme, they tolerated everything, food, mold, pollen, nothing bothered them. After Lyme, now they're hypersensitive to their world. So we know there's a shift in the immune system. It can really upset your Th1, Th2 balance. Th are T helper cells, and Th1 cells kind of, are the defenders of your immune system. They go after anything that's foreign and kind of gobble it up. Where Th2 is more antibody driven. That's what drives allergy. That's what drives a lot of autoimmune processes. So, we're always trying to keep that seesaw relatively balanced. But, in that, when we disrupt the immune system, we create this sort of storm of hypersensitivity where now, again, your world becomes foreign. And in that, that can happen with anything that's been prescribed to you. Again, whether it's an antibiotic, herb, vitamin, mineral, anything like that can be problematic. And, I try to generally start people at relatively low doses of things and kind of make sure they tolerate it first before we increase the dose. That doesn't always work out, but as much as we can. And it's amazing how many people, when they start to take things like an amino acid or something that's unrelated to killing Lyme, they start to have this reaction that sounds like a herx. Oh, my stomach aches. I feel more tired. My brain's foggy. That may have absolutely nothing to do with a true die-off. Unless you're giving something to kill the bug, it's probably not a herx reaction because that's part of killing the bug. So if you're having these symptoms after you start taking something else, it could just very well be that your liver doesn't process it well. You're having a mast cell activation from that substance. So it's the tightrope that we have to walk with you to make sure that we're giving you things that work well for you, but nothing that's provoking any kind of mast cell problem, allergy issue, hypersensitivity issue. And if it is, we need to either stop it or we need to scale the dose back.
Yeah. It's just so well said, and so important to understand that all these things are happening. It's like you mentioned medical gaslighting, and you're not the first person who said that to me, and it's like we've all been there. We are right now we are not part of that group that's trying to say that, but what we're trying to do is clear the air so that you can actually get better. And one of the things that you keep talking about, Darren, is immune dysfunction, and how maybe Lyme kind of tweaked out your immune system. It's very well known to do that. What are some of the things that you're using in practice that might be ways to, because like in my brain, I think since I see a lot of kids, I think about pans and pandas, right?
Right.
Charles Ray Jones said, infection triggered autoimmune encephalitis. And I just go and step out a little bit, and infection's a type of toxicant. Let's call it a toxin, or most people call toxins incorrectly, but whatever. Toxin-induced autoimmune encephalitis or inflammation. And I need to think about those other pieces, including that big part called immune system modulation and autoimmune kind of rebooting, or whatever you want to call it. What do you, because the thing is, people are suffering, right? As we said, we're not saying you're not having these symptoms. What we're talking about is you have them. Let's find out if they're from Lyme or mold or Bartonella or Babesia. And if they're not, doesn't mean you don't have them. It just means that we need a different label. And if we the doctor comes up with a different label, then we can do that. So what are you doing in your practice to kind of reboot the immune system, get it back on track, so that maybe I came to see you with Lyme, I now am sensitive to my whole world, and I am even convinced, you're convinced, the lab's convinced, everybody's convinced I don't have Lyme anymore. And
Yeah.
what do you do?
We do a lot of immunotherapy in our practice, and there's different types of immunotherapy. One of the things that's come out in the last, less than 10 years is called LDI, or low dose immunotherapy. Dr. Ty Vincent, who's a medical doctor out of Hawaii, really kind of developed this. And it comes out of another allergy treatment called LDA, or low dose allergy therapy. And the idea is that if your immune system's treating this bug as an allergen instead of a pathogen, it's engaging a completely different part of the immune system. And I think that's what triggers a lot of symptoms related to these infections, including the autoimmune process. So basically, you take dead bug, you can take Borrelia, you can irradiate it, you kill it so it can't reproduce, it can't cause infection, but it maintains all those little bits inside its little bacterial body that we can use to retrain the immune system. And then we dilute it out literally millions, billions of times to the point where it's really homeopathic. And we mix it with an enzyme called beta glucuronidase. And this is an enzyme that's naturally found in your body. It's in white blood cells. But we found that it seems to modulate whatever you mix it with. So we've got different dilutions of Lyme and Bartonella and Epstein-Barr and Candida. And so we can select the antigen that we think is provoking the symptoms. And sometimes that's based on blood work or a stool test or a urine test to give us clues about what your exposure is. And then if we find the right antigen, the right dilution, I mean, for some people, it's been a game changer. And if you think about it, it's like, well, okay, if there's 1 million Borrelia in your body, that's going to provoke a big immune reaction. If we can use herbs or antibiotics to bring that down to 1,000, well, now there's less stuff to aggravate the immune system. And then we can use something like LDI to modulate the way the immune system is reacting to whatever is kind of residual. And, for something like PANS, this is important because it's not uncommon that PANS is triggered by something that's part of you. It's part of your normal flora. If you react to strep, for most people, strep's part of their normal flora. So this idea that you're just going to eradicate your way out of it, that's just not going to happen. And we see this often with PANS where kids go on antibiotics, they get improvement because now you brought that organism load down. But as soon as you come off the antibiotics and the load goes up again, they're right back to having symptoms again. So we need different strategies that just aren't targeted on killing the bug. And LDI, I mean, again, for some people, it's really been a game changer. The downside to this therapy that people need to be aware of if you haven't tried it is if we have the right antigen and the wrong dose. So if we give you a dose that's too strong, it can actually make your symptoms worse. And here's the good news of that, is that it's also proving that that's what causes your symptoms. So if I give you a Lyme 14C dose and your headaches get worse, I've now just proven that Lyme's what's making your headaches worse. It's the headache specifically or Lyme, where, my joint pain didn't change at all. Oh, maybe your joint pain isn't Lyme, maybe it's something else. So there is a little bit of a diagnostic aspect to this therapy. Dr. Vincent's been doing this for a decade. We were there at the beginning with him, so we're about the same time frame. And I know he's trained hundreds of doctors around the country, around the world on doing this therapy. So it's out there. But the nice thing about it is that, again, it's safe. There are people who do get aggravations. In our practice, often we will start people at dilutions that we think maybe aren't going to do very much. And then if there's really no change, then we'll inch our way up, because each 1C is a 1 to 100 dilution. So mathematically, it's a 1% difference. So we keep inching up by 1%. You think about it like a drug. If you started with 1 milligram, then you went to 5, then you went to 10, then you went to 25, but maybe your dose is 100 milligrams. It might take some time to get there, but in doing that, the likelihood of getting any kind of adverse reaction, it just goes way down. And I know in Dr. Vincent's practice, he kind of goes the other way. I think he's willing to give people a higher dose to provoke somebody, to prove it's part of the problem, and then figure out the right dose. But I've had enough experience with people getting really bad reactions, and it sucks for people. So I've learned that it's usually better to start small and kind of work your way up. But LDI, again, can be really helpful. And then again, if you become hypersensitive to pollen or mold or food or chemicals, we can do LDA or low dose allergy therapy. I do a lot of what's called sublingual immunotherapy. These are drops you put on your tongue that are very much akin to doing allergy shots. We just don't inject it. So we can do allergy testing, find out what actually provokes you, and then based on that information, make up drops that you put under your tongue. So we've got all these different types of immunotherapy that can be powerful tools to really transform your immune system, build your immune tolerance again, so these things don't keep upsetting the balance in your immune system.
Stuff is awesome. I love, like, to me, I think one of the big pieces of this is that the dysregulated immune system that kind of gets in that survival mode, and it's trying to protect itself, and it's react to against things that are not even like autoimmune is like kind of going after viewing yourself as not self, so having the opportunity to use something that's so safe and so effective. And I really like, it's interesting, when I started my practice, I would do a lot of proving with herbs. I was taught you do like a, you do the trial to confirm your diagnosis, and then you do the treatment dose. Man, I did that for a couple of years, and I was beating the crap out of people. It's like, you start at the highest dose of the herb, and I'm like, no, I'm pretty sure I know what's going on right now. My spidey sense is well tuned, taken a good history, done a great exam, done some lab. Why don't we just start the treatment and work up to it? Because I definitely don't see the people. I see people kind of like you do, who probably aren't going to want to tolerate a big nuclear fallout just to prove that they have what we all know they already have. So I think that that's a great way to do it.
Yeah, and I should also add that low dose naltrexone, again, for some of my patients, has really been a game changer. Even though it's a medication, I mean, I'm a naturopath, I'm supposed to tell you that medication's bad, but I use a lot of low dose naltrexone, and have found it, again, being a very potent immune modulator for a lot of people. And it also can be really helpful for pain, for a lot of Lyme patients, whether it's joint pain, muscle pain, headaches. This medication binds to opioid receptors in the brain, and then when it unbinds, it stimulates the own release of your own natural opioids. These are your natural painkillers. So they've done research on, inflammatory bowel disease and rheumatoid arthritis and other autoimmune diseases and autism. Unfortunately, they haven't done any studies in Lyme specifically. I actually wrote the chapter for the LDN Trust book on using LDN for Lyme disease. Again, I've treated hundreds, if not thousands, of patients with LDN. The nice thing about it is that it's incredibly safe. The side effect profile is very, very benign. Some people, when they take it, because usually we recommend you take it at bedtime, they might get weird, wonky, vivid dreams. And sometimes that goes away after they've been on for a while. And for people who really doesn't go away, we have them take it in the morning. So I've had very, very few people that just for whatever reason didn't tolerate it. And the other nice thing is that it's very inexpensive. Like our pharmacy here in California, a 3-month supply is about $45. So for something that's reasonably expensive, has a good probability of helping. My experience with LDN has been about 50-50. 50% of people get clear benefit, 50% of people does nothing. But for the cost and the safety, I think it's worth trying for a lot of folks. And this is something else to consider as part of your regimen.
Yeah, I'm with you all the way. Like, I was actually going to chime in that my pharmacy is $54 for 3 months, but you got me. But no, it's like, but what's really interesting, Darren, is like, I've seen people who are on IVIG with PANS diagnosis get better, but when they try to stop the IVIG, they relapse immediately.
Yeah.
That I've put on LDN and been able to get them off of IVIG. So you're talking $45 or $55 for 3 months versus $15,000 a month and getting a human blood product. Or I've seen people where they can't get IVIG or they can't get their immune system balanced out, where it works really well. I think the way you describe it is the way I describe it to my patients. I just think it's very interesting because, I mean, we talk about LDN a lot, but it's like literally, I was like, that's exactly how I describe it. So the profile is really safe. It works really well. I also have seen people with like scleroderma and other manifestations. Like some people look like they have a sword cut on their face and it's all indented. And I treat them with the antibiotics that are going after the infections that we find. And I add in the LDN, they're off antibiotics. They're on the LDN. Their pain is completely gone. And this big divot in their forehead is 50% better. And I've seen people with like really, yeah, dude, it's like, it's crazy. And like, I've seen like people with more, instead of the localized scleroderma, like their whole chest is all like looks like dried out leather, like,
Yeah.
I don't know what I'm trying to think of, like chainmail garment shield thing, and you get them on the proper treatments for their infections, it doesn't change much, but you get them on the proper treatment for their infection, you modulate the immune system really that you're talking about using LDN. And all of a sudden they have, 7 months go by, they have almost normal skin. A year and a half go by, you wouldn't even know. So I think that there's so much to be said for the different immune modulating pieces. So I'm really glad that kind of like you're able to bring that together. And also just so excited about hearing that your experience and mine with the safety profile of all these things is very similar. And, so I agree a lot with taking those. As we kind of land ourselves here, because I have no idea how long we've been talking for, I just so you guys know, like Darren and I, when we do this, sometimes we've been known to have a schedule an hour live event, and we'll do it for 2.5 hours just because we get going. So, but we're going to try to, minimize that as we kind of land it for today, at least, Darren, because I know we've got a lot of extra bonus things we're doing as part of the summit and after the summit, so people can get a lot more of this. As we wrap this together, I mean, are there any pieces of immunity, autoimmunity, the immunotherapies that you do that we've kind of not touched on, or is there something you want to kind of land us with?
No, I just want to let folks know that this is not something that a lot of clinics do. Unfortunately, there are a lot of doctors out there, a lot of environmental medicine doctors that work with immunotherapy. But again, it can be such an incredibly powerful tool. And again, because Lyme looks like so many different things, if Lyme has caused some element of immune dysfunction, it's difficult to know what's Lyme and what might be due to something else. I mean, I've had people with terrible joint pain that they chalk it up to Lyme, but come to find out that they're sensitive to nightshade foods. They get nightshades out of their diet. Now their joint pain goes away. Had nothing to do with Lyme. So, you're a practitioner, you're a constant detective. We're always digging deep, always looking at the clues, looking at how you respond to treatment, because this, tells us the broader story of what's going on with your body and how we need to change things. But if this isn't something you've really investigated, Dr. Vincent has a lot of great YouTube videos on LDI. I've got blogs on my own website about LDI and immunotherapy, so definitely check it out.
Cool. Well, Dr. Darrin Ingalls, every time we get a chance to hang out is a pleasure and an honor. I'm just so I'm so grateful that you're taking the time out of your busy schedule to help bring in a different perspective to the summit, bring in some of the people that and interview people from a different perspective than I would, so that we can give the best to everybody. And if you guys aren't aware, you haven't seen some of Darren's stuff, definitely check out his book, The Lyme Solution. I think your website is DarrinIngelsND.com, if I'm not mistaken.
Yep.
I've been stalking you. But like I said at the top of our conversation, the reason I love working with Darrin is we have similar but very vastly different experiences. And we really like to blend that science with the art of medicine and then dispel some of the myths. And all the stuff we talked about, there's this scientific base. And as we move forward and you're going through learning the different things, find that practitioner, like Dr. Darrin was saying, that really resonates with you, so that they can help you be the captain of the ship, be that objective person that really helps you be able to implement these things. There are so many options. And just because Darrin just said LDA, LDI, and LDN, it doesn't mean you need all of those, right? You may or you may not, but work with someone like Dr. Ingalls, who is an expert in figuring out which ones you may or may not need. There are a lot of people who need a lot, but a lot of times what it's interesting, Darrin, and I think about like how many people have done so many things, and then one thing works and they say, oh, everybody in this support group, you need to do what I just did. If you're not doing it, you're doing it wrong. If your doctor's not recommending it, they're doing it wrong. When really what it was they got lucky after doing a bunch of things, or they're working with someone who's very strategic and gets them to that point, but they also did 75 other things to get there. So just to kind of really highlight working with someone who's got that really expert level, who and can be objective for you, I think is really important. So I appreciate how you brought that together. Love the conversation about polyclonal activation, because it is such a big deal. So Darrin, thank you so much for this opportunity and for being part of this. And everybody, make sure you keep tuning in and check our show notes. make sure we're doing our things every day for you to kind of like help go through and guide you through the summit, but also some of the things that we're doing together at post summit to help with some ongoing learning and healing. We're really excited to share with you. So, and Dr. Darrin Ingels, thanks for joining me. Love partnering with you on this one. And it's so great to be able to share this amazing information with the world and doing it with you.
Great. Thank you, Tom.
Thanks, everybody. Dr. Darrin Ingels, naturopath and immunologist extraordinaire, with me, Dr. Tom Moorcroft, and we're signing off for this episode of the Healing with Lyme Disease Summit, but we're both looking forward to seeing you in our next episode. And until next time, lots of love. Heal up soon.